Good evening, everyone. Myself, Dr. Satish Arge, working as a consultant, Emergency Department, Yashoda Hospitals, Secunderabad. Today, I would like to take this opportunity to invite you all to this webinar series conducted by the Emergency Department, Yashoda Hospitals. Every week, Department of Emergency Medicine, Yashoda Hospitals come up with an interesting topic in the webinar as a continuous education program. So this week, today, we have a very exciting topic called killer ECGs in emergency diagnosis and management. ECG is a very important investigation in emergency department. It helps in identifying acute life-threatening cardiac emergencies like MI, like VT, SVT, heart blocks, which helps in immediate intervention and treatment. And ECG is a very vast topic, and sometimes it is ambiguous. Every time we see an ECG, we get to learn a new thing. Yesterday, I learned a new pattern in ECG that was a South Africa flag sign. It was like ST elevation in lead 1, ABL, V2, and ST depression and lead 3. It was the first time I've seen in our ED. So today we have with us Dr. Malay Misra to talk on this exciting topic, killer ECGs in emergency diagnosis and management. To briefly introduce about him, Dr. Malay Misra is working as a senior consultant and academic head at Emergency Department, Yashoda Hospitals, Hitec City. He worked as a senior consultant and HOD at Max Hospital, Gurgaon, and also Manipal Hospital, Jaipur. He was also a member of many societies like Society of Emergency Medicine, and he was also a member of Emergency Medicine Association of India and Indian Society of Toxicology. He's also a course director and teaching faculty for Masters in Emergency Medicine program run by George Washington University, USA. And he's also, not but the least, he was also a faculty for national conferences like Toxicon and ToxCare. So with this brief introduction, I would like to welcome Dr. Malay Misra to take over the mic. Thank you.
Thank you so much, Dr. Satish, for a brief, very illustrative discussions about myself and this topic. This topic is really very, very essential for all the people who are working in day and out in emergency settings. So I think we are already late, so we should start at early. So before putting my next slides, I would like to ask whether you can able to see it or not. Briefly about this ECGs. How we should read these ECGs? Basically, they should be having a rate, rhythm, axis, and morphology. The step-by-step approach we should be knowing to read the ECGs. So as you can see in this ECG, there is mild elevation in lead 1 and lead AVL. Apart from that, we can have this ST elevations in the precordial leads like V2, V3, V4, V5, and V6. So basically, what type of MI is this? It is basically anterolateral wall MI. This is basically extensive wall MI. Coming to the next ECG, you can have it basically that changes is more or less same, like it is the ST elevations are there in lead 1, AVL, and little changes you can see it in a V2, V3, V4, V5, and V6. So basically this is extensive anterolateral wall MI. Coming to the next one. So this is a classical ECG findings in ST elevation MI. We just call it that tombstoning pattern. Basically, it's a gray prognosis. So you can figure it out. The elevations are very, very high. It is more than 10 mm elevations. All the leads having precordial leads. Even this is lead 1 and AVL also. Certain reciprocal changes are there, lead 2, 3, and AVF. So this is called tombstoning pattern, and this is very, very grave prognosis. If you fail to treat, the patient will end up into ventricular arrhythmias like ventricular fibrillations or ventricular tachycardia. Coming to the next ECG, this is a classical STEMI pattern. You can say it's called as the bumpy part. This is called convex upwards. So this is a very dangerous ECG to have, untraval MI. Coming to the next ECG, you can see here long spikes in the inferior leads 2, 3, AVF. Okay, and certain changes in the V3, V4, and V5. So you should not forget while seeing these ECGs in a lifetime. These are all various characteristics approach of STEMI. The next, yeah, this is very, very classical. This is called shark fin sign. So what happens exactly here? You can call this as lambda wave. There will be giant R waves or triangular this QRS complexes. ST and T changes are there. They're making a waveform. This is called shark fin sign. And this ECG talks about the same thing, like there are changes in the inferior leads 2, 3, and AVF with the reciprocal changes in lead 1 and AVL. So this is a new concept that is called OMI manifesto. What happens basically? What is OMI? It's basically an occlusion of myocardial infarctions. So what happens? This is a branch of ACS algorithms representing near or total occlusions with insufficient collateral circulations using active infarctions. So this is what happens in OMI. Many of the times we tend to forget the ECGs, and patients with occlusion of myocardial infarctions are those that benefit for early emergent reperfusion therapy, in which the benefits outweighs the risk for invasive procedures. The another concept is called NOMI, that is non-inclusion myocardial infarctions. So under the current STEMI program, 25 to 30% of NSTEMI patients are found to have total occlusions on delayed cardiac catheterization. So using these expert ECG interpretations instead of strict STEMI criteria, now the cardiologists are going for aggressive early reperfusion therapy. So now coming to the case. So there is a case, 44-year-old male, hypertensive, presented to emergency with angina. So you can see in this ECG there are hyperacute T waves, and there are classical findings. Can you see it? So this is what is called Deventers T waves. It's a classical ST depressions and peak T waves discovered by Robert Deventer in 2008. So there are like ST depressions and peak T waves in the precordial leads. We need to be familiar with this kind of ECGs, because if we will miss it, there is a high chance of patient collapsing, and we need to send this patient as early as possible to the cath lab for early interventions. So basically, there's consists of 2% of total acute LED occlusions. So this is STEMI equivalent, and we should understand this. This is called acute proximal LED occlusions. Coming to the second case, it's called 58-year-old diabetic female with complaints of dyspnea and exertion, referred in view of ECG changes. So you can see this classical ECG changes, that's called Wellen syndrome. But this pattern is basically pain-free state, and there will be deeply inverted or biphasic T waves in the chest leads, that is V2 to V3. It may extend up to V1 to V6. So there will be no precordial Q waves. There will be recent history of angina, and sometimes we'll have elevated serum cardiac markers. So we should understand this. This is called critical LED stenosis. More than 2/3 develop interval STEMI. Remember two things here. This pattern is usually present in pain-free state, and it may be obscured during the episodes of ischemic chest pain, where there is pseudo-normalization of T waves, so that you can say isoelectric or minimally elevated ST elevations. So this Wellen syndrome is a key example of all patients presented to emergency, why you need to have a repeat serial ECG monitoring. So as I said, there are two types of Wellen syndrome. One is type 1, one other is type 2. In type 1, you can have biphasic with initial positivity and terminal negativity. This is only 25% of cases you will have this Wellens type 1 pattern. And many of the times when patient presented to us, it will be type 2, that is deeply and symmetrically T waves. So it is almost 75 to 80% time we see Wellens pattern type 2. So this T wave changes can evolve over time from type 1 to type B. So it's a matter of time. We need to detect early so that treatment can be done on early basis. Coming to the third ECGs, there is a 72-year-old male presented to emergency with severe angina, vomiting, and near syncope. He has features of pulmonary edema. So you can see here there are ST elevations in AVR. So what does it signify? Like ST elevation in AVR and multi-lead ST depressions suggestive of left main coronary artery stenosis. There will be proximal LAD stenosis or severe triple vessel disease. And sometimes when the patient is having cardiac arrest and you resuscitate the person very carefully in an emergency setting because of hypoxia or hypotension, for example, this resuscitation from the cardiac arrest, you might have this elevation in the AVR. So basically, what are the causes of ST elevation in AVR? There will be diffuse subendocardial ischemia because of due to lack of oxygen or demand mismatch. Second thing is infarction of the basal septum. So coming to the next, that is left main coronary artery occlusion. It's a misnomer. There was severe study. One of the study was a single center retrospective analysis in 2019. University of Arizona, they have included 99 patients where they had like 10% had occlusions. None of these lesions were involving LAD or left main coronary artery. So it doesn't represent acute left main coronary artery occlusions as once thought. So it could called as non-occlusive myocardial infarctions. There is another case, that is 53-year-old male with complaints of severe angina. So you can see there are ST elevations in the AVR and widespread ST depressions in V4 to V6 with lead 1 and lead 2 and AVL. So ST elevations is only in two things, AVR, V1 and V2. This is the pattern is called a Slanger pattern. So there will be inferior ST elevations isolated to lead 3 and concordant ST depressions in any of the chest leads that running from V4 to V6 with a positive, terminally positive T waves. This specific ECG pattern representing acute inferior occlusion MI in patients with concomitant multivessel disease. So there was a study in NJM, a new electrographic pattern indicating inferior myocardial infarctions. It constitutes almost 13.3% of all inferior MIs. So we should not forgetting this classical Slanger pattern. Coming to the next case, this is a 53 years old diabetic male complaining of acute onset chest discomfort, which is radiating to the left arm. So you can see here, there are ST depressions in V2 and V3. So this is a classical significance of posterior wall MI. So posterior infarctions comprises almost 15 to 20% of all STEMIs, usually occurring in the context of inferior or lateral infarctions. You can see there are mirror image changes in V1 to V3. There will be horizontal ST depressions and reciprocal changes. The mirror image changes will be ST elevations. There will be tall upright T waves. And you can see the T inversions in the mirror image in V3. There will be tall broad R waves. And in the mirror image, you will have Q waves presentations. So the basic important factor here is we need to fix the posterior leads. So posterior infarctions is confirmed by the presence of ST elevations and Q waves in the posterior leads, as you can see here, from V7 to V9. And the V7, basically we need to put it here as left posterior axillary line in the same horizontal plane as V6. V8, we can put it at the tip of left scapula at the same horizontal plane as V6. And adjacent to that, we can put V9, left paraspinal region. So the next case is a 68-year-old female complaining of 1 hour severe chest pain. So you can see here, there are culprit vessels, like there are elevations, slight elevations in lead 1, AVL, and there will be reciprocal changes in the lead 3. This is called high lateral occlusion MI. There will be complete occlusion of the first diagonal branch of LAD, that is D1. And this is classically called South African flag sign. You can see here, there will be ST elevations in lead 1, AVL, and sometimes in V2 also. But there will be reciprocal changes in lead 3. So the culprit vessels here is first diagonal branch of D1 of LAD may produce isolated ST elevations in lead 1 and AVL. Second, the occlusion of left circumflex artery that may cause ST elevations in lead 1 AVL. Along with sometimes they will be having changes in the V5 and V6 also. So we should remember this. This is called high lateral occlusion MI, and the classical sign is South Africa flag sign. Coming to the next ECG, there is a 51-year-old female complaining of 1 hour severe chest pain. So you can see here, there are ST elevations in lead 3 and there are reciprocal changes in the AVL. So this is called inferior posterior wall occlusion MI. There is another case, this 80-year-old female complaining of 3-hour onset of chest pain with normal cardiac enzymes. You can see it here. There is only 1 mm, hardly 1 mm elevation in lead AVL. So any cases for this will be typical LBBB pattern. This is called Sgarbossa criteria. There will be modified Sgarbossa, concordant ST elevations more than 1 mm in any one lead. Like here you can see there is ST elevation in lead AVL. There will be concordant ST depressions more than 1 mm in more than one of the lead, like V1 to V3. Or there will be proportionally excessive discordant ST elevations in more than one lead, anywhere within more than 1 mm ST elevations, as defined by 25% of the depth of the preceding S waves. So the sensitivity here for this modified Sgarbossa and Smith is 91%, whereas the specificity is 90%. So there is another ECG, 39-year-old male complaining of recurrent episodes of syncope. There is no chest pain. So any guesses for this ECG? You can have this clue, reverse tick sign. So basically, this is called Brugada syndrome, developed by the Brugada brothers in 1992. It is basically because of sodium channelopathies. The diagnosis depends upon the Brugada sign, like I said, reverse tick with clinical conditions. So the ECG changes are very transient, and there will be curved ST segment elevations more than 2 mm in more than one any precordial lead starting from V1 to V3, followed by negative T waves. And there will be sudden cardiac death. That is very, very important to understand. A mortality of 10% per year. And the treatment is implantable cardioverter defibrillator. That is the definite treatment. And sometimes it has been shown that quinidine has been proposed for an alternative settings where these ICDs are unavailable. So there are three types of Brugada syndrome. One is type 1. You can see it here. That is called curved ST segment elevations more than 2 mm in any of the V1 to V3 leads by a negative T wave. Type 2 has more of saddleback shaped deformity. You can say it is more than 2 mm of saddleback shaped ST elevations. That is type 2 Brugada. And sometimes you can have morphology of either type 1 or type 2, but with less than 2 millimeter ST elevations. That is called saddleback shaped. So there are three types of Brugada. Very commonly seen is type 1. Coming to the next slides, that is another case, 20-year-old man with palpitations and syncope, hemodynamically unstable. Elder brother had a history of sudden cardiac death at the age of 28 years. So you can see this patient needs what? Urgent cardioversions. The post cardioversions, you can see there are classical findings here. That is called epsilon wave. So this is the second most common cause of cardiac death in young people after HOCM, accounting for almost 10 to 15%. So the treatment, this is called arrhythmogenic right ventricular dysplasia. So the classical finding is epsilon wave. There will be T wave inversions in V1 to V3 in the absence of RBBV. There will be prolonged S wave of stroke, and there will be localized QRS widening. Sometimes we will have ventricular ectopics of LVV morphology with frequent preventricular contractions. So the treatment part is antiarrhythmic as well as anticoagulant, and sometimes the person need to go for ablations, and the definite treatment is implantable cardiac defibrillator. Next is 34 years old male presented with syncope, BP not recordable. He has previous history of syncope. You can see this classical ventricular tachycardia. Post cardioversions, this is the changes. There is a classical findings here. Any guesses? This is called whole Parkinson-White syndrome, and that is called delta wave. So the peer interval will be less than 120 milliseconds. There will be delta waves, and QR prolongation is more than 110 milliseconds. There will be pseudo infarction pattern. Normally you can see many of the times there will be ECG in sinus rhythm, but slurring of slow rise of the initial portion of QRS complex in the opposite direction to the major component of QRS. There will be classical findings called delta wave. So remember, delta wave is a pre-excitation phase of WPW syndrome, and whereas the epsilon wave, you can have this post-excitation of arrhythmogenic right ventricular dysplasia. So remember these two things, it is very, very important. The last, I think the second last case is 53 years old female brought to the emergency department with chills and rigors in North Sikkim. Her peripheries were cold. So there is a classical findings here. Any cases? This is called Osborne wave. So positive deflections at the J point. The classical is hypothermia. There are certain non-hypothermic conditions like hypercalcemia, Tokosovo cardiomyopathies. That is very, very classical findings of Osborne waves. Normal variant of early repolation also can have neurological deficits, severe myocarditis, and Brugada. Sometimes we'll have Osborne pattern. This is another case, 16-year-old male brought to the emergency department with generalized body swelling and deranged renal functions. What is this rhythm? This is a very more interesting ECGs. Every day and out we used to see. Remember this pattern, this is called sine wave pattern. We're talking about hyperkalemia. What is the first sign you will have? Tall tented T waves. Next is prolonged PR and absent of P waves. And there will be slightly widening of QRS complexes subsequently. And last will be sine wave pattern. Then it will be ventricular fibrillations. So the next case is 5-year-old female with complaints of recurrent syncope. You can see any classical findings. There will be prolonged QTC. So long QT syndrome, basically it's a genetic disorder of channelopathies. More than 440 milliseconds in males, ECG evidence will be there, and it will be need to address very early. And for females, it should be more than 460 milliseconds. So the hallmark of this arrhythmia's long QT will be torsades deep oranges. So basically, there are certain factors that involves for long QTC. The examples are the drugs like class 3 antiarrhythmics, that is amiodarone, tricyclic antidepressants, many antibiotics, particularly macrolides, antifungals like fluconazoles, quinidine, haloperidols, methadone, and sometimes SSRIs. The most common what we see in a doctor practice is ondansetrons. Metoclopramide use can have long QTC prolongations. So there are certain genetic factors as I discussed. There will be channelopathies. There will be myocardial disease like MI, myocardial infarctions, rheumatic fever, third-degree heart block. Sometimes you'll have long QTC and cardiomyopathies, HOCM and all. You will have sometimes long QTC syndromes. So electrolytes, like I just said, low calcium, low potassium, and low magnesium can cause prolonged QTC. So we need to be very, very thoroughly while reading these ECGs for a young populations like pediatric age group. This is the sudden cardiac cause of children or young adults. So this is very, very important to understand. Discovered by Javel and Lang-Vincent syndrome. Another one is Romanon-Ward syndromes. So this is another case, 57-year-old female, known case of CA breast, presented with dyspnea on exertions and chest pain. Any classical findings? You can have this electrical alterance, low voltage ECGs. So there is echo findings also here. Sinus tachycardia in the ECGs, there is low QRS voltage, less than 5 mm in the limb leads and less than 10 mm in the precordial leads. That is called electrical alterance. You can see the amount of fluid around the cardium. So that is called cardiac tamponade. Next one is 74-year-old female, known case of CVA when bedbound conditions, now presented with aspiration pneumonia and septic shock. These are classical ECG findings here. Any guesses? It's called spiked helmet sign. These are domes and spiked sine wave pattern like appearances. These are pseudo ST segment elevations. There will be upsloping that begins prior to the QRS complex. So this is called spiked helmet sign. The patient is into severe sepsis, critically ill, and high chance of mortality. So this is what I have taken the ECGs from the Smith's ECG blog. Thank you so much for patient listening. If you have any doubts, please put up in the chat box. I'll be able to answer all these queries. Thank you so much.
Thank you, Dr. Mishra. That was a very wonderful presentation. We are glad today we learned many ECG patterns.
Thank you.
Some of them we have already known, and some of them which have like refreshed our memories, and we get to learn new ECG patterns also today. And like ECGs we discussed, like Wellen syndrome, Brugada, De Winters. These are not routinely seen in EDs, but yes,
Yes.
we need to know about these things because these are serious cardiac emergencies. If we don't
Yes.
diagnose early, they can lead to cardiac arrest and death.
Yes.
So, so we need to give emphasis on learning these kind of not uncommon presentations also, so to will help us in prompt diagnosis and treatment.
Yes, definitely.
Yeah. Now, like we are open for the questions from the audience, and Dr. Misra will be answering them.
What's going on?
Any questions, please?
I'm sure you must have a lot of questions.
Yeah, they are hesitating to ask you, I think. Yeah, there is one question. Uh, this is from Dr. Parvez from Oman. How frequently do you encounter Brugada syndrome in your ED?
As I said, it is very, very rare. It is not that common, but we should always have a idea of knowing what is Brugada in ECGs. Should back up your mind. See, many of the times people are on white complex tachycardia, like all the sodium channelopathies drugs, they will have white complex tachycardia. So you should always have a close look on the ECGs.
One more question we have. How to get HOCM on ECG?
So basically there will be sinus tachycardia, there will be LVH pattern, and with unstable vitals. In the echo findings, there will be cardiomyopathies, there will be poor LV, there will be the pattern will be basically LVH strain pattern. And this is the most common cause of death in young populations.
Any more questions? Yeah, one more questions. With the same person has posted. The person who has posted about how to get HOCM has posted like
Yeah, with
no
no
symptoms.
symptoms, like there will be patient presented with shortness of breath sometimes, and sometimes it will be mild chest discomfort, but it is not a regular clinical presentations.
Yeah, one more question we have. Can you please explain once again on infero-posterior occlusion MI changes in AVL?
Yeah, there will be ST elevations in lead 1, and there will be in like I have said, there will be South African flag sign. You can have lead in lead 1, and in lead AVL there will be reciprocal changes in lead 3. So this is very, very important. In basically in inferior posterior wall, the occlusion of MI, there will be ST depression in the lead AVL, and there will be elevations in lead 2 and lead 3. So we need to understand, we need to have a more than 1 mm of elevations also we need to take care of properly. There will be OMI, that I said, occlusion myocardial infarctions. These patients require early reperfusion therapy in an emergency setting.
So any more questions? Dr. Misra is eagerly waiting to answer your questions, and
I think everyone has understood.
yeah, I think everyone has understood. Yeah. Okay. That was a very wonderful session by Dr. Misra,
Thank you.
which has enlightened us about killer ECGs. Really, they're killer ECGs. Okay,
Thank you
then.
so
Thank you.
much, Dr. Satish, for a nice introduction, and overall, you are just moderating my session. It's a great honor and privilege to work in Yashoda Group, and I hope we should continue this webinar in future so that we can have a brought up the discussion part as well. It's a nice interacting you all. Thank you.
Yeah.
Thank you so much.
Definitely, Dr. Misra. Thank you.